right. Yeah, okay. So thanks everybody for coming to this month's Hour of Power. I am super excited about this particular topic. It's one of those topics that I think, none of us wants to admit, but it is seemingly a very real thing. And as we get older, as athletes, we have to deal with this more and more, it seems like. So I'm hoping that our fabulous guest, Dr. Rosemary, who I will let you introduce yourself in just a second, is going to answer all our questions about pelvic health, incontinence, and anything else that needs to be discussed in this topic. So, all right, Dr. Rosemary, I'll let you take it away.
Okay. So I'm Rose. I usually go by Rose. I'm a physical therapist. I work here in Boise at Rock and Armor. We have our Garden City clinic, and I work over there. I will kind of just sorry if you can hear the cat in the background. I'll just give a little background. So I grew up in Moscow, Idaho. And I went to University of Idaho for my undergraduate, and I got a degree in exercise science. And then I went and got my Doctor of Physical Therapy degree from Eastern Washington University. I did a short little stint in travel therapy. I did like rural hospital PT. But then at that time I was looking for a little more mentorship and stability. So then I went and did both pelvic rehabilitation and outpatient ortho at a sport clinic in Washington. And then after a while there, I decided to come here, be closer to family. And now at Rock and Armor, I see a lot of outpatient orthopedics. I see a little bit of pelvic health, a little bit of sport, kind of all over. But I really like kind of mixing all of it together. So, yeah.
That is excellent. And I will say, Rock and Armor is a great physical therapy clinic. If you guys need therapy, that place is awesome. I spent half my life there, I feel like. Good therapists all the way around. So I would say maybe the best thing to do is, well, actually, Rosemary, you can either start with the questions or you can start with an overview or however you want to do it. So
Sure.
you do it.
I figured one of the first things we could talk about was just what is the pelvic floor? Just because I think it's kind of become more discussed in, especially like the fitness world with athletes. We talk about the pelvic floor a lot, but I think what it is still kind of vague for a lot of people. So basically, I like to think I'm very visual, so we'll kind of go over like a simplified version first, I guess. So we can kind of talk about like the abdominal cavity and the relationship to the pelvic floor. One of the easiest ways to visualize it is if you think about your abdominal cavity like a soda pop can. At the top, you've got your diaphragm, your big breathing muscle. Your torso, the cylinder is going to be your abdominal muscles and your back muscles. And at the bottom of that soda can, you have your pelvic floor. The pelvic floor is basically a bony basket. Your pelvic girdle is that bony structure that has a basket of muscles, nervous structures, blood vessels, as well as connective tissue. And the primary role of the pelvic floor is to support our pelvic organs. So that would be like our bladder, our uterus in females, rectum, supporting those pelvic organs, and then also assisting in our bowel, bladder, and sexual function. It also has a really important role in our core stability, in our breathing. It is working all the time. It's one of the most important parts of the body, I think, but that's because I kind of, obviously focus on that a lot. I always kind of talk about the pelvic floor, like in the PT world. Pelvic PT is getting talked about a little bit more now, I think. A lot of people go to PT for orthopedic injury, and pelvic PT is in principle the same thing, just a different area of your body. So you have muscles in that area that contract, relax, just like other muscles in the body, like your bicep contracts and relax to do its function. The pelvic floor muscles contract and relax for their function as well. So rehabilitation applies a lot of those same principles. Yeah. Any questions about that?
Anyone? I have a comment.
Yeah.
So I actually listened to a actually I don't even know what it was. It was a like a podcast, but anyway, it doesn't matter where it was, but it was a podcast. It was done by I don't know, are you familiar with Stacy Sims, Dr. Stacy Sims, and her work at all? Okay,
I
doesn't
don't
matter.
know. I've heard her.
Yeah, she's done a lot of research with females, with athletic females, which has been super helpful because that's a group that has not really been studied very much, especially with research studies and experimentation, etc. So her work has been super helpful. But she had a gal on who was a physical therapist also, and doing exactly this topic for particularly for females, but obviously it applies to males as well. But that physical therapist, that gal said something really interesting. She said, which I had not really heard. She said, if you have problems like incontinence problems, that is not normal. Like everybody has, a lot of people experience it, but it's not normal, meaning it should be solved. And I had
100%.
not really ever heard that, which kicks me in the butt because I
Yeah.
need to work on this a lot harder than I have. So,
Well, I mean, that was just the narrative for so long is like, I think so many women, especially women, because pelvic dysfunction is more common in females. There just for so long, it was like, oh, if you have kids, you're just going to be leaking after you have kids. That's just how it is. Or you're just going to have that abdominal separation. That's just how it is. And it is common, but that doesn't mean that it's normal. That's what a lot of people say now. It's common, but that doesn't mean normal because you can work through that and you can, like do the right exercises, do the right programs to help reduce that. But I think for a long time it was just kind of like, oh, you just live with it, and that's just how your body is now. And you don't have to accept that. Yeah.
yes, that makes me very happy.
Yeah.
All right. Do you want to get started on the questions?
Sure.
All my
So,
questions, or I still have all my questions.
ooh, okay. Okay, so let me kind of pull them up here because I did write them down. Okay, so some of them kind of go together actually. So first we can kind of just talk about what incontinence is, I think. So incontinence is there's multiple kinds. There's urinary incontinence and there's fecal incontinence. Mostly kind of talk about urinary incontinence because that's a lot more common. It's basically involuntary leakage of urine. And that can be little amounts, I mean, tiny, tiny amounts, or that can be a lot. That can be enough that you have to change your clothes, or it can be enough that you're like, I just feel like a little bit came out. That's all defined as incontinence. The main ones that really, there's like two main types, and then there's a lot of subtypes too. So there's stress incontinence. And basically that is any kind of urinary leakage that occurs when you are putting stress on the pelvic floor. So that typically means things like if you are increasing your intra-abdominal pressure, like you're lifting something heavy or you're coughing, you're laughing, even if you're like jumping on a trampoline and you get that kind of bounce through pelvic floor and you have some leakage, then that's considered stress incontinence. So it's any incontinence with that stress on the floor.
So that would include running.
Yes.
Yeah.
Yeah, that like high impact.
Yeah.
Anytime you like hit the ground, abdominal contents essentially are going to drop down with that impact. And so it's going to put that extra pressure on the floor. And if the pelvic floor is either, not coordinated or it's weak or it's tight, or, just doesn't kick in at the right time, then that can create that leakage of bladder. And then the other main type is urge incontinence, which is basically urgency is that like sensation to go to the bathroom. And so people with urge incontinence will have like this strong urge to go, and then they're not able to hold it up to the point that they go to the bathroom. Both of these, they have so many different causes. There's usually not just one cause behind them, which if there was, it'd make my job a lot easier, but there's a whole lot of stuff that goes on behind it. We can talk a little bit more about both of those. There's more common causes, but there's a lot of different factors at play for sure with those. But yeah, those are the two main ones. There's other ones too, like there's mixed incontinence where you have both. There is what they call functional incontinence, which is typically in like older individuals that are just not able to physically get up to go to the bathroom. And then overflow is like you can't really sense your bladder filling, and so it'll literally fill all the way, and then you have that overflow incontinence. And that's typically more associated with like neurological conditions, but stress and urge incontinence are the most common.
And are those, so you're saying that those two have potentially different, but also potentially the same causes?
Yes.
Yeah.
Yeah. So, I mean, with anything we talk about today, obviously the best thing is to go to a pelvic PT and get assessed because there are so many different causes. But yeah, so like stress incontinence, a lot of times, like that, I would say that's more related to athletes typically. It is a lot of times caused by like poor coordination of your core and your pelvic floor muscles. So a lot of times they will hear like, oh, you just need to get your pelvic floor stronger if you have any kind of leakage, right? Like do some Kegels, do some pelvic floor contractions, get that pelvic floor stronger. But many people that I see that have stress incontinence, they actually have decent pelvic floor strength. It's just that their pelvic floor is not kicking in at the right time. So say they like land, they run, hit the ground, and their pelvic floor is just not coordinated at the right time. So I would say is like one of the more common things I see. Or it's just like an issue with loading. So people will kind of, just like with any strength training program or any kind of athletic training, you want to progressively load over time. So they'll progressively load, their leg muscles, all these other muscles in their body, but not really thinking about how you have to progressively load your pelvic floor also to like train to handle that load. Because that increase in the abdominal pressure coming down makes those muscles have to work just like any other muscle in the body.
And sorry, guys, I'm just going to just keep asking questions. So if you all have questions and if you have things that come up, please, and you haven't given them to her already, please just jump in. So how does that compare men to women? Since we have guys in here as well.
Yeah. It does occur in men as well. As any of these pelvic dysfunction does. It is a lot more common in women. I don't know the exact numbers off the top of my head, but it's definitely more common and more common in postpartum women, more common in women after menopause. And part of that is just because there's literally a shorter length of like the urethra for urine to leak through. And that's like honestly like a big part of it. Also women have a greater like pelvic outlet, like a bigger space where those muscles span across at the bottom of your abdominal cavity because of childbearing. So then that does lead to more risk for dysfunction in those muscles.
And are the male incontinence issues, are they termed differently, or is it all kind of the same terminology?
It is the same terminology. And I mean, I should also note that I definitely specialize typically more in female pelvic floor. So that's what I know more about, but yeah, they have the same terminology. It's still stress incontinence, urge incontinence, all of that.
Okay. Great.
Yeah.
Excellent. Okay.
Could urinary incontinence also be caused by, I mean, you said stress. So for example, like before a race, I often get just, I mean, even though I know I'm not going to win the race or anything out, I get really nervous.
Yeah.
And I mean, I don't usually have the incontinence problem, but I absolutely have to go to the bathroom. I mean, 2 minutes before the race, I'm like, oh man, you know, and it's like, you know, you've been 5 minutes before, but then I've got to go again. And so would that be stress? Would that be considered to be stress or nerves or?
That's a good question. So that stress is going to be a different kind of stress. It's super common. I call it the anxious peas because that's
That
what it
sounds
is.
right.
I remember doing like in PT school before practicals, I'm like, I just peed and I'm going to pee my pants again because I'm so nervous. But that, yeah, so that's a different kind of stress. And again, there's a whole lot about that kind of stress too, like psychological stress and how that impacts your pelvic floor. That's a pretty big thing. When we are stressed, we think back to like the olden days when you are, being chased by a lion, tiger, or bear, you get a stress response, that fight or flight response, and your pelvic floor is going to tense up in response to that. Because when you're being chased by a lion, tiger, or bear, you don't want to be pooping and peeing yourself, right?
Preferably not.
Yeah, probably not. But now in, modern day, we have a lot of psychological stressors and there's I see a lot of people who have like really high anxiety, lots of stress, and their pelvic floors are just really tight all the time because they're just always holding that tension. That sensation of tightness in the pelvic floor too, like if those muscles are holding a lot of tension, it often creates the sensation of having to go. So that will create an urgency for a lot of people. And so that's like what happens if you're like really anxious before a race, you might have a little bit more tightness in the pelvic floor. And that can make you feel like you have to go to the bathroom.
So how does that concept, that stress concept, or that tight tension, how does that relate to like you go to the bathroom but you can't get it all, like if you're still, you feel like you've gone, but then you stand up and you're like, oh, now I have to go again, and then you stand up and you're like, oh, I have to go again. It's like you don't ever get it all out.
Yeah.
Complete voiding, is that, talk about that.
Yeah, so that is called incomplete voiding. Voiding just means going to the bathroom, emptying your bladder. Most of the time, like you said, that is from an inability to relax. So when we are voiding bladder or having a bowel movement, really what's happening is we should be relaxing those pelvic floor muscles and kind of just like letting everything go. Because I'm going to kind of use my hands here. Normally, your pelvic floor should have like a resting tone where it's like right here. When you are doing something like jumping, it should contract and go up. And then when we're going to the bathroom, it should relax, come down, open up a little bit. If we're kind of stuck in that stress response or we're unable to relax, then we're not going to be able to fully let go of bladder and let it empty all the way. This can happen a lot of times, like I'll see a lot of teachers and healthcare workers, people who are like, I'm just going to pee really fast and then go. And then they don't really relax when they're going to the bathroom. And then they get in that habit of incomplete emptying of the bladder. That, like, one of the best tips for that is just taking your time in the bathroom and like giving yourself a full minute, trying to create like a relaxing environment, doing some deep breathing. Pay attention to your jaw. So if your jaw is clenched, your pelvic floor is probably not relaxed either. So just kind of taking the time to create that relaxing environment. Some people too, like there's something called post-void dribbling, which is like if you feel like you go to the bathroom and then you stand up and then like a little bit comes out. That could be for a couple of reasons. It can be partly that like when you stand up, you're letting go of some tension, and then that, a little bit of urine comes out. A lot of times we'll see it if people have a prolapse. So prolapse is when the organs in the pelvic floor drop down a little bit. So a lot of times like the bladder will drop back and create kind of like a pocket. And then when you stand up, that pocket opens up and that little extra pool of urine right here is going to drop forward. And so for that, you would kind of lean forward a little bit, sort of shake out your hips and then try again before you stand up.
Is that something that needs to be solved? I mean, I know of women, particularly, I don't know about men, but women who have had that prolapse situation actually surgically fixed. But then I've heard not great things about that surgery either, in terms of it just comes back again.
Yeah.
Really, I mean, what's the solution set for that?
So the way I approach it, I think if you're not having symptoms really associated with it, or the symptoms don't bother you, I don't think it really needs to be fixed. A lot of times the surgery associated with pelvic prolapse there's like mixed studies on it. Some say that they are beneficial in like reducing your symptoms, but there's also a higher risk with like you could have higher risk for pelvic pain later or incomplete emptying later. I mean, obviously, I always advocate for conservative care first, so trying to go to a pelvic PT. But they've shown that like a lot of people have pelvic prolapse and not really have any negative impact of that. One of the biggest, like I saw this one study that said one of the biggest like negative outcomes is just like body image. So women who have pelvic prolapse, even if it's asymptomatic, even if they have no other form of pelvic dysfunction, like they have no incontinence, no pain, it just kind of messes with your body image a little bit. But I mean, I think it really depends on the person. If they have some pelvic dysfunction associated with that, then it might be worth reducing. But if they don't have that, then I don't feel like it's really necessary.
Is it possible for that situation to correct itself? Because my sister-in-law she was diagnosed with a prolapse uterus. And she was having a lot of difficulty. And then all of a sudden, she was all scheduled to have surgery. And then, I don't know, a couple months later, it was like, oh, she doesn't have it anymore. And I'm like, what? So, I mean, is it possible that by doing certain exercises, she could have corrected it on her own, or?
Yeah, definitely. I mean, that's what we would do with PT. Of course, it depends on what you'd find in a pelvic exam, but say there is muscle weakness in the pelvic floor, the pelvic muscles are going to have a pretty big role in supporting those pelvic organs. So if you're able to strengthen those muscles and create a little bit more support, that can help reduce prolapse. Or other exercises that I'll work on with people are like breathing exercises and core coordination. So if you are straining a lot on the toilet, if you're going to have like these improper breathing techniques when having bowel movement, or you're lifting and you're really like bracing down, that can exacerbate a pelvic prolapse. But if you go over, breathing techniques for that, that can help to reduce that prolapse naturally. There is a certain point though. So like if the prolapse, there's like 4 grades of prolapse. If it does go beyond a grade 2, so in women, that's like you can actually visualize that prolapse coming out through a vaginal opening. That is when it is it typically doesn't respond as well to conservative care. And that's typically when they'll do surgery, or you can get what's called a pessary, which is like this. It's just I don't know. I almost want to say it's like a tampon that just like helps keep things up, but that's more of like just like a comfort thing. Yeah.
Right. Good stuff. Good stuff. Yeah. So what's on the question list there that you haven't touched on yet?
Well, there were some questions about abdominal doming, which I think were good questions. So, what is abdominal doming? And then also, how is it related to menopause? So, abdominal doming, the clinical term for that is diastasis recti, which is basically a separation of the abdominal muscles. It's not a hernia. A lot of people think that maybe it's a hernia, but you do still have some connective tissue in your abdominals that prevents like abdominal contents from coming out, but you do see that pressure between your abdominals. There are, again, many causes for that. It can be poor breathing strategies, poor bracing strategies. It's really the most common after pregnancy. It's also common in men, older men, because they carry more weight around their abdomen. So that creates, that little bit of separation in the abdominals. A lot of times it's asymptomatic. It's not really like correlated to be like, there's some studies that show that it correlates to back pain or abdominal pain, and pelvic floor dysfunction. There are other studies that say there is no correlation. So yeah, and it's one of those things that if it's not symptomatic, it's not going to hurt you by any means. For a lot of people, I think the cosmetic aspect is what is the most bothersome. If you have like that kind of bubble between your abs. That is typically solved with, I shouldn't say solve, but you can kind of reduce the appearance of it with learning to engage your core properly. So working on like your deeper core muscles, and just learning how to manage your pressure within your abdominal system, that soda pop can system. That can be really helpful.
So is that connected or not connected? Sorry, to incontinence issues and that sort of thing? Are those different, or they can overlap?
It is connected. So it's kind of like if you have a diastasis, it doesn't necessarily mean you will have pelvic floor dysfunction. I think it's more as you get older, if there is a diastasis, it's more associated with pelvic floor dysfunction. And part of that is if you have a diastasis and you are not able to engage those core muscles appropriately, it's more like that poor core coordination is associated with the pelvic floor dysfunction. So if you have a diastasis, but you're able to use your muscles the right way, or in the way that we hope to see, then it's less associated. And then there was a question on there about how is it related to menopause, which menopause is a very complicated thing. So I actually was like, I was doing a little research on it because I was curious about that question, and I didn't really see a lot of studies saying that like with menopause you are more at risk for a diastasis. But I think it would make sense just based on all the other things that occur with menopause. So kind of talk about menopause first. The biggest thing with menopause is a drop in estrogen. And that drop in estrogen is associated with a lot of other physical changes like more fatigue, more weight gain, more abdominal weight gain. There's lower bone mass density. Typically, people will adopt a more sedentary lifestyle in menopause, not because it's like, oh, all of a sudden I went through menopause, I'm just going to be lazy or anything like that. It's just like the change in energy levels. It also has been shown to, like, if your estrogen drops, and there's a whole like process with your cortisol and your progesterone that kind of increases or slows down your colon function, which can lead to like constipation. And then you might have some issues with like trying to bear down and strain a lot with going to the bathroom. That might be, associated with that diastasis during menopause. But really, I think it's kind of like this domino effect of like, if you are less active in general, if you are straining more, then those kinds of things are going to put you at more risk for diastasis. Does that make sense? That's a lot. Menopause is a lot.
Such a huge topic.
What's that?
Such a huge topic.
Yeah. Yeah, and I'm not an expert in that by any means. But...
Oh, but you will be.
Oh, yes.
One day.
If there's anything you want to know, just ask.
Yeah, I know. There's 3 of us in here who can talk about it. And the guys could probably talk about it too from their wives' standpoint. Although guys go through a little bit of, I mean, you don't call it menopause, but you do go through hormonal changes, which is the same kind of thing. So yeah.
I will say I did see another study that showed that, like, they usually say about 30 to 40% of women, this is another female study, but 30 to 40% of women will experience urinary incontinence prior to menopause, and over 50% will after. That's honestly, I feel like over 50% is such a vague thing, because I feel like it's definitely over 50%. It's probably a lot more than 50%. And one reason for that is that drop in estrogen does lead to more tissue dryness, and that tissue dryness is associated with more like pelvic tension, which can decrease your pelvic function or inhibit your pelvic function. Also, like basically dries up the mucosa in the urethra. So normally you have like a little bit of like that mucus tissue or mucus substance that kind of helps to seal the barrier between your bladder and the outside world. But then when you have that drop in estrogen, you get a little more dryness, you kind of lose that. So those are both kind of some theories behind why urinary incontinence increases in menopause.
Well, back to that podcast I listened to, it was interesting because the gal said, yeah, she said in athletes, it's female athletes particularly, I mean, it's almost guaranteed. And the gal that was interviewing was like, well, why would that be? And she said, well, just think about it. For athletes, especially endurance athletes, you're asking all your muscles to be under load for a really long period of time, including your pelvic floor.
Mm-hmm.
And so if that pelvic floor is already compromised, you're going to put it under load for a really long period of time in running or cycling or whatever you're doing. And you're pretty much, I mean, it's almost a guarantee that, particularly for females, that you're going to have that problem as an athlete, as an endurance athlete. I thought that was really interesting. It's like, okay.
Yeah, you're like, yay.
We're not alone, ladies. We're not alone.
I mean, that being said, I feel like you could say say the same thing about a lot of different things, like, oh, every endurance athlete's going to get knee pain or something like that. But we have learned to train for that a little bit better. And I think we just need to learn how to train for the pelvic floor a little better too. And I think maybe we're getting there, but it's still like an ongoing, like there's a lot more research that needs to be done and a lot more talk that needs to happen. Yeah, I think it's trainable for sure.
Well, and I mean, I have a friend she's late 20s, and she had her baby in Germany. And oh my gosh, I mean, they're like pelvic floor everything. I mean,
Yeah.
she's like going to bi-weekly appointments for physical therapy on pelvic floor rebuilding and health. And I was just, kind of listening to her talk, and I'm like, oh my gosh, I mean, my doc said nothing about that when I had my baby. I mean, there was like no thought about like, oh, maybe you should go rehab that. So
Yeah,
it is. I mean, I'm hoping in the US it's getting better too, but in Europe it's a huge thing. Like I was amazed at how much she was focusing on that, her doctors were telling her to focus on that already, like right off the bat.
Yeah.
So
Yeah, that's really cool.
Mm-hmm.
I think, I'd like to see that here too, for sure. I would say there are more doctors now that are advocating for pelvic PT. It's just like standard of care after having a baby. And like, even if it's just an assessment to be like, hey, does everything feel good? Is everything great? Like having a baby is a huge, I don't like the word trauma, but like it's a big event for your body, and it doesn't really make sense that it's not followed up with like care right after. They're like, here's this life and bye. Like, I don't know, it doesn't make much sense.
Exactly. Yeah. All right, guys, what you got? What you got for us? What you got for Dr. Rose? We can't hear you, David. We can't hear you.
You can type it.
Now you're muted.
His microphone's off.
I know, but he wasn't before. Let's see if I can unmute him from my end. La, la, la. Let's see.
Hey, Michelle, can you hear me?
Yeah.
Okay. I wanted to go back to that whole issue of having to use I know this isn't incontinence exactly, but the whole issue of having to go to the bathroom so much, like before a race or an athletic event, because we're so nervous. And I did understand the difference, but is there anything that you recommend that could help us with that situation, or is it just a matter of relaxing? Any advice you have on that?
Yeah, definitely. So this is one of my favorite things to teach people because I think it can benefit from it. So there's this thing called urge suppression. So that urge, that sensation to go, there's this technique where you can help decrease that sensation to go. Obviously, if your bladder is full, like if you're like, yeah, actually, I haven't peed in 2 hours, you should go. But if you have good suspicion that your bladder is not actually full, but you have that sensation to go, you can go through this technique, which basically, it's a way of like retraining your brain and your involuntary connection to your bladder. So normally that sensation to go is associated with this muscle that sits on top of your bladder. Your bladder is like this. This muscle called the detrusor starts contracting right on top of it. It's involuntary, and that's what really makes you feel like you have to go. This muscle, the detrusor, has an inverse relationship with your voluntary pelvic floor muscles. So when this muscle contracts, normally your pelvic floor wants to relax so that you can go to the bathroom. But if you can actively contract your pelvic floor muscles, then it helps to relax your detrusor muscle. So what you would do in that instance, say you really have to go, you stop what you're doing, you take a nice big breath, that kind of helps with that relaxation response. And then you do 5 quick Kegels or pelvic floor contractions, I like to call them, because Kegels is outdated, I guess. So pelvic floor contractions. And when I say quick, it means you don't want to be doing like a hold. You want to do a quick, like contract, 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 relax, take another big breath, and then do something kind of mentally distracting, like count backwards from 100 and sixes or whatever, something that just makes you not think about it for a second. And then you can kind of tune back into your body after like 30 seconds or so and ask yourself if you still need to go. That sensation to go should be a little more decreased because it should help to reduce that detrusor activity. So you shouldn't feel like that sensation to go is as strong. Now, if you still really have that sensation to go, then you can go to the bathroom. Just don't rush. So that's another thing is like people will be like, oh, I still had to go, so I ran to the bathroom. But if you do that, you're really just like teaching your bladder and your brain that like when you have to go, you're going to go right that second, and then kind of lose your ability to really hold your bladder. So you want to like take your time. I kind of joke that like you do like a bride march to the bathroom just to kind of tell your body like you're in control. You know, you're in control of your bladder and it's not in control of you. And practicing over time, like the first few times you do it, it's going to be really tricky, but it does get easier. But yeah, you should feel like decrease in that sensation to go with that.
That was very helpful. Thank you.
Yeah.
So I explained before that I have the nerve urinary incontinence before races, but probably my worst problem is the other kind of incontinence, the fecal incontinence, which I have analyzed about myself for years. Why is it this always? I've played around with my diet. I've like 3 or 4 days before a race, I've cut out all dairy products. I've, avoided heavy meats. I mean, I've done all kinds of stuff to just like, it's gotten better. I mean, I have to say it's gotten better, but I haven't been doing any really long races lately, but I just wonder, I mean, if there are other things other than dietary, or if there are dietary things that you would recommend, or, that, you should avoid these, or you should, whatever, that would be very helpful.
Ooh, yeah, I mean, you started off with a lot of the right things, changing diets, kind of just seeing if there's any kind of pattern there. This is one of those things, honestly, in an ideal world, seeing a pelvic physical therapist for an assessment would be really helpful, because if you've already kind of played with your diet a little bit, or, seen your doctor or gone over that kind of stuff, it may be a muscle issue. So it could be a weakness issue. It could be a coordination issue with those pelvic muscles. I think that's something that's always worth assessing. Yeah, I know that's kind of a tricky one. I do think that getting an assessment is really like the best thing you can do in that instance. I wish I had a better answer for that.
Usually once I get going in a race or whatever, I can talk myself out of it. But I'm always glad that there's a number of porta potties on the course, because I may need them if it's a long one. But yeah, I just, it's gotten easier to deal with it, or as I've gotten older, because one, I'm running slower. And I think, and I'm not trying to get a PR or anything like that. And so I kind of can control it in that way. But yeah, for me, I think it was a real dietary thing. I really think that I had to be very careful with what I ate, days before a race.
Yeah, that's tricky. There are I think a lot of times people are like, oh, if you have any kind of bowel issue whatsoever, they're like, increase your fiber, but I don't really talk about like what kinds of fiber to increase, because there's different kinds. There's one that will just kind of clear you out, which is maybe not what you need if you're having fecal incontinence. And there's one that will kind of bulk up your stool a little more. So that's also another thing to consider. I can even email you a whole list of the different kinds of fiber if you'd like. But that's I think a lot of times we're just like, okay, use as much fiber as you can, because that's what you're supposed to do if you're having any kind of bowel issue, but kind of playing with what kinds of fiber you need can also be helpful.
David, were you able to type your question? Because we can't hear you. I can't hear you, and you're not muted. Can you type it or text it to me? Yeah, that doesn't help me. Or actually, Rose, you might have his question.
Yeah, I'm looking at it right now. Hold on. Why is that coming? It's hard for me to answer because I'm not entirely sure what is meant. So yeah. Is maybe like what happens if there is incontinence after, if that procedure happens?
Is that what you're asking, David? Can he hear me? Can you hear me, David? Yeah, we can't hear you at all.
Well, we can email chat or something.
Yes, yeah, guess
Yeah,
at what he needs and then answer that.
Sorry about that. Yeah, did I answer all the other questions?
Anybody else?
Oh, are there specific exercises that we should do all the time to prevent incontinence?
Yeah, that's a good
I wish. I wish there was. That kind of goes back, I was saying that like a lot of times I think we're kind of getting out of it, but for a long time it was like, oh, we don't really understand the pelvic floor. If you have issues, just do some Kegels, do Kegels at the stoplight, do Kegels all day long every day to try to solve those issues. And that is really outdated. So don't do that. Honestly, the one thing I could think of that would be just like generally good for preventing incontinence is what many of you are doing, which is staying active in general. So just like good sleep, good nutrition, good hydration, and staying generally active has been like shown to be the most protective factor in reducing risk for incontinence. Which I mean makes sense. Just be healthy in general is a great way to reduce that. But that being said, obviously it still occurs when you are healthy in general. I would say from just like what I've seen in the clinic, understanding like your core coordination and your breath control can be really, really helpful with stress incontinence. Because like I said, most of the time when I see that, it's people who are maybe like gripping down on their core and really bracing down and just not really like working their pelvic floor up against that pressure. And that leads to stress incontinence. Another thing would be like avoiding straining on the toilet. So kind of start paying attention to your bladder and bowel habits and make sure you're not like, doing a Valsalva to try to have a bowel movement. That's not really what we want. We do want that kind of push, but not like a full on, like as much intra-abdominal pressure as you can. You don't necessarily want that. So practicing like healthy habits in that way too. Ooh, and also a big one for urge urinary incontinence. Like I said, a lot of people I see with urge urinary incontinence, it's typically people who are really like high stressed or high stress type A, like go kind of people. So stress management is really huge for that. So, being able to try to take some time to relax every day is really, really helpful for that. And not going to the bathroom just in case. So that is a really big one. I used to do it all the time where it's like, oh, I know I'm gonna drive home, like, yeah, I'm gonna go drive to, an hour, so I should probably just go just in case, even though I went 5 minutes ago. And what happens if you do that a lot is basically your bladder normally should have like a couple sensations when it has to go. But you start decreasing when you actually go to the bathroom. So now, say normally at like 70%, you're like, I have to go to the bathroom. When your bladder's 70% full, you get that, really strong urge to go. Now, if I go when my bladder is like almost empty all the time at 20%, then your brain is going to start thinking at 20% that it's full. And then you're going to have to go a lot more often. When normally we should be wanting to go like every 1 to 2 hours throughout the day. That's kind of like what they say the normal frequency is. That kind of changes person to person, but I'd say that's like a pretty common issue I see is people are like, oh, I'm just always rushing, so I just go, just in case all the time. I go before I do this and I go for that. And it's like, well, now you're peeing every, 10 minutes. So then you just like train your brain to do that. Yeah.
As far as the fecal incontinence, are you opposed to like taking antidiarrheal medication before, like if you've got a race coming up or whatever and starting to take it, a couple of days before or whatever, or do you think those are not a good idea?
I don't know. So I think it's a good question for a PCP, a doctor, a physician, just because I'm not really educated on the medication aspect of it. So I don't really want to, give any wrongful advice there.
I mean, I've used those things before and I've just wondered, they can be a little tricky because they can have the adverse reaction. I mean, they can, when they're supposed to help you not go, they in fact do the opposite. So I've had different reactions. The one doctor that I went to recommended that I start taking, like I had a race on a Saturday and she said, okay, Thursday, take a half of one. Friday, take a half of one. And then on the day of the race, take a full one, like X number of hours before. And that seemed to work fine. But like taking it like the day of or the day before, kind of didn't work.
Yeah.
So,
oh,
yeah.
no.
Yeah. So I don't know if there's something in the medication itself that,
Yeah.
didn't agree with me or something, but
That's interesting. I don't exactly know, like, I mean, I learned it a long time ago, but I don't exactly know the mechanism of how those
Yeah.
medications work. So I don't really know what would cause that.
So we just got to get ready for a colonoscopy and then we'll be ready to go.
Oh gosh, yes. And I only do those every 5 years. So yeah, those are fun.
Then there's no problem, right?
Yeah.
All right, you guys.
Those are my favorite activities. They are getting easier, I have to say. They're getting easier. Instead of having to take 14 gallons of stuff, now it's just like one little bottle or whatever. So yeah.
All right, guys, we got about 7-8 minutes left. If anybody's got last minute questions. Oh, I see a chat here. Okay.
Yeah. Okay, so the chat says, how important is regular hydration to establish good rhythms? And I'm assuming that's for like regular bladder voiding. It's huge. So, I can't remember if Michelle, if you and I talked about this a lot for some reason, I feel like it kind of came up, but basically a lot of people with like, if they're going to the bathroom too often are going to try to decrease their water intake because they're like, well, if I drink too much water, I'm going to have to go all the time. But dehydration is actually a bladder irritant. So when you're dehydrated, sometimes it has this opposite effect where it makes it feel like you have to go more often. So hydrating regularly throughout the day is very, very important for good bladder health. The goal for that is typically like you want to take your body weight in pounds, divide it in two, and that's how many ounces of water you want throughout the day. It's going to feel like a lot at first for a lot of people. That means if you're, 200 pounds, you drink 100 ounces of water a day. And you don't want to drink that all at once because your body just won't have time to absorb it. And then you're going to have to pee right after. So ideally, I've got my very trendy Stanley cup. Yeah, I like the straw because then you can just sip it all day and not drink too much at once. And, that's like the ideal way to get your hydration in. And then also, if you notice you're going to the bathroom at night, you typically want to start reducing that water intake 2 hours before bed. That doesn't mean you can't drink any water. Like if you need to take medication, that's fine, but not drinking like a whole glass of water right before bed, which a lot of people will do because they're like, oh man, I didn't drink enough water today. And then they just like chug some water before bed and then they have to get up 2 hours later to pee. So that's another thing that's just trying to wait or kind of finish that hydration 2 hours before bed. So hopefully that answers that.
Yeah, that's good. That's good stuff.
Yeah.
Anyone else? David, you sent me the map game.
Yay.
No, he said too long to get into now, another time. Okay. Oh, Harold's got another chat. Okay, chat's going crazy. 100 ounces is the So I will say something that can help too, and I don't know how you feel about this, Rose, but I add a little salt, just a little bit of salt to my water, not every glass, probably I'd say every other glass that I do. And that actually has helped. Well, I started doing it because I get nighttime cramps in my calves and feet a lot, and that has greatly helped. But it also helps my body retain the water so that I'm not peeing it out quite so rapidly throughout the day. So that has been.
Do you put that in every glass you drink, or
no? I probably do every other. So I fill it up. I just pinch. Yeah, just a pinch in.
Yeah,
so.
And that's for electrolytes too, right?
Well, salt is an salt is one of them. I just use salt. Right. I don't use any other electrolytes. So
yeah.
But I'm not doing big, huge workouts either that need a ton of stuff. So
yeah.
But that has helped 2 problems. So the nighttime cramping problems and the peeing all the time problems.
Yeah. I just attributed, having to go to the bathroom at 2 o'clock in the morning to being old.
So that I have to every night. Every night. Yeah.
I mean, I don't care. I don't drink water 2 hours. I mean, I'm like what you were suggesting about 2 hours before. I don't drink any, but I still have to get up at 2 o'clock in the morning and go to the bathroom.
Yeah.
So yeah.
I think lots of people have to do that.
Yeah. I think
the trick is, can you get back to sleep? That's the trick.
So. Yes, usually I can.
Yeah.
Yep.
That's the hard one. That's when I have trouble.
Absolutely.
That's a whole nother topic. We need a sleep person. I need to find a sleep person to get on here.
Oh, that's a good idea. Yeah, I could use one.
Great idea. See if I can find one. All right. Any last comments, questions? We got like 2 minutes.
No, but I just want to say to Rosemary that I love her last name because, I mean, how appropriate is Coldsnow? I mean, yeah, it's like,
Thank you.
yeah, I just love it. It's great.
Yeah, it's really easy to spell. Well,
Yeah.
actually, a lot of people get it wrong, surprisingly. I think it's like this mental,
Oh,
like,
they want it to be
there's
like
no way
German,
it's-
so it's
Yeah.
K-O-L-D
Really unique.
with the, yeah,
Cold Stone, like the ice cream. I get that a lot.
yeah. Very cool. It's a very cool name.
Thank you.
Nice. Yeah, so if anybody is interested, I can certainly get Rosemary's contacts to you if you need that. She can be found at Rock and Armor out on
Like
Chinden.
Yeah.
Oh,
Chinden.
Chinden. Oh,
Yes.
so
Oh,
you're
yeah.
out
Yeah, Boise City.
Chinden and what? What's the crust?
What? I think I would know.
It's by the fairgrounds.
53rd by the Fred Meyer.
Oh, okay. Oh, yeah, that's not far at all from where I live.
Yeah.
Awesome. Yeah.
Cool.
Jared's down there, my favorite therapist in the world. Rosemary, of course, is there too. So
Yeah.
um,
Very cool.
good clinic, definitely.
Yeah.
All right, y'all. Well, thank you so much.
All right.
I appreciate this
Yeah.
very much. Dr.
Thank
Rose.
Thanks for having me.
And you
Thank you,
guys
thank
can
you,
all
thank
kind
you.
of guess what I look like because, yeah, that's my face right there. So
Look like a camera with a line in it.
A line
just
through
got a
it.
big camera head. That's all.
All right,
All
you
right.
guys.
Thank you.
Have a lovely night and stay tuned for next month. We got some more good stuff coming your way. So
Sounds good.
all right.
Thank you. Thank
Thanks,
you, Michelle.
everybody.
Thank you, Rosemary.
Thank you.
Take care.